7 years.
8 years.
I did fall pregnant and I had a miscarriage.
It was the worst pain in my life.
I'm destined to be a mother.
Yeah, it's become our world.
We can't be silent about it.
Women don't want to talk about this. But what if we put our problems there for everyone to see, to help other people?
The Salome range of products tackle issues of infertility, menstrual pain, and heavy menstrual bleeding.
Female infertility, but specifically about endometriosis and PCOS. So these are huge topics, and I've only been given a few minutes to talk about them. And I'm hoping to give you some few minutes for Q&A afterwards. So I'm going to just give you the important points that I think really are relevant to you. Then you can ask me anything else beyond that. So, female infertility, we know that the causes of infertility can either be male, female, there's a combined factor, there's an unexplained factor that we don't know what the cause is. But in the female infertility, you see that there's ovulatory disorders, disorders of menstruation and ovulation. Then it's tubal factor infertility, when the tube is blocked or has been cut or any of those issues. Then there's an unexplained factor, and then there's problems in the uterus, the womb. So PCOS belongs to the ovulatory disorders, and as you can see on that slide, it takes quite a big part of the ovulatory disorders. Endometriosis, on the other hand, also takes up quite a big part of the tubal factor in infertility, and it accounts for about 20%. So now we're going to go into the different disorders, and I'm going to start with endometriosis. So what is endometriosis? Is when the cells of the lining of the womb, which we called an endometrium, those tissues, when they appear outside of the endometrial cavity. So that's what endometriosis is. They're supposed to be in the endometrium, which is the lining of the womb, but they can go out and implant everywhere else in the pelvis. So you can see from this slide that is quite a common disorder. 1 in 10 women that are in the reproductive age group, which means if we take a whole general population of women between the ages of 19 and 49, then 1 in 10 of them will have endometriosis. And it's estimated that worldwide there's 175 million people that are affected with endometriosis. But I say that this is an underestimation because we don't diagnose it enough. So often people go with a problem of pelvic pain to their doctor and they are told it's an infection and they are given antibiotics. Then it doesn't get better, they go back, they get more antibiotics. So we don't diagnose it enough. So you can see also that it also impacts on infertility. 50% of women with endometriosis have difficulty falling pregnant. So we don't know what causes endometriosis, but there are some theories that have been postulated to say this is possibly the reason why people get endometriosis. And the one that is most accepted is the Sampson's theory, which says that the tissue or all the cells, instead of going out with menstruation through the cervix and vaginal, they go through the tubes and implant everywhere in the cavity. But other theories says that there's transformation of some cells in other areas of the body, and then possibly that it can spread through the bloodstream or the lymphatic system to other parts of the body, because I'll show you in another slide that you can also find it in the lungs, and it doesn't explain why it went out of the tubes. So it means that it went either through the bloodstream or the lymphatics. So because it implants everywhere, we get these three phenotypes of endometriosis. You get the superficial implants, the little spots that you see. When you do a laparoscopy, you see spots of endometriosis. Alternatively, it can be in the ovary and present as an endometrioma. And this is a chocolate cyst. It becomes quite big. And if both ovaries are involved, they can be big enough to touch each other. And we call those kissing ovaries. Or it can implant anywhere in the bowel or in the urinary tract, either in the bladder or in the ureters. It can basically implant everywhere. So that we call deep infiltrating endometriosis. So as I said, that you don't only find it in the peritoneal cavity, which means in the pelvis. You can find it outside. Sometimes people complain that they are bleeding through their umbilicus, their belly button, during menstruation. That is umbilical endometriosis. Some will complain that a previous scar, either from a cesarean section, keeps on bleeding when they are menstruating. That is also a scar endometriosis. And as I said, it can be found in the lungs, under the diaphragm. It basically can be found anywhere. So what is the problem with endometriosis? It causes pain, and this pain is very debilitating. If any of you have seen anyone with endometriosis, this is the biggest problem, that they are in severe pain. And this is either caused by adhesions that are caused by the endometriosis, or the inflammatory response from the endometriosis, or it implants on the nerves and causes pain, or the distension of the ovary when it's the cyst in the ovary. And it also causes infertility. If you can imagine, I've put in a picture there of a tube. If it causes adhesion, it causes the tubes to block. And we need this fimbriae to pick up the egg during ovulation and put it in the tube so that the sperm and the egg can meet in the tube. So if it has an endometrioma or it has endometriosis, then it's not going to pick up if the fimbriae are damaged. So it causes pain, it causes infertility. So how else does it present? So the usual presentation of endometriosis is dysmenorrhea, which is painful menstruation. It's dyspareunia, is pain during intercourse, and it has to be pain during deep intercourse. And then it's chronic pelvic pain. It's pain that is continuous and doesn't stop at any time. It can also present as infertility, has other symptoms, bleeding through umbilicus, as I mentioned, flank pain or blood in the urine. This is when it affects the renal system. Then it can also present with pain during passing of stools. That is when it's implanted in the bowel. And then some people, when they can cough blood, during their menses, and that is called catamenial hemoptysis. So what's the management? How do we treat it? And it's not always that we have to operate endometriosis. Surgery should be the last option. So we should really be decreasing the number of surgeries we are doing. We should avoid surgery as much as possible. And you should go to someone who's an expert in endometriosis surgery. Please ask, if you've got endometriosis, ask your doctor or gynecologist, are you well trained in endometriosis surgery? Because we've seen people getting damaged because of surgery that's not properly done. You can imagine, I said that it causes adhesion, so things are stuck inside there. So if they are stuck, the bowel is stuck to the bladder, to the uterus, and then someone makes a hole in the bowel, you can end up with a colostomy. So we don't want someone who's not well trained to do the surgery. So again, there's a recurrence of endometriosis. That recurrence is 20%. So if someone gets operated, it recurs a year or so later, they go and get operated again, it recurs again. So we don't want people to have multiple surgeries. So what we propose is that you should have medical treatment first, and surgery should be reserved as a last option unless you've got things like an endometrioma, which you need to deal with. So, but the medical treatment does not make the endometriosis goes away. It only relieves the symptoms, and it doesn't treat the endometriosis, has no effect whatsoever when you've developed that cyst in the ovary, and it's not for the deep disease. It's not going to make that deep disease go away, but it is an option when we are dealing with pain. So it's important to ask your patient what is the problem, what is the complaint, because if the complaint is pain, then you must relieve the symptoms of pain. If the complaint is infertility, then you must deal with infertility issues. So you can give any combined hormonal contraceptives. These are oral contraceptives and the patch that you can give. You can give progesterone-only medication, which is either the levonorgestrel intrauterine system, that's the Mirena, it's an intrauterine device. You can also give injectables as long as you're giving any of these hormones. Then you can give things like the GnRH analogs. So these other options that can be given. This is all part of medical treatment. What you need to be aware of is this medical treatment, most of this, they prevent pregnancies. So if your complaint is you want to fall pregnant, this is not the option for you. So it's important to know what it is that the complaint is and manage it appropriately. So now we're going to talk about PCOS, Polycystic Ovarian Syndrome. This is also quite common. 1 in 10 women have polycystic ovarian syndrome, but is not properly diagnosed in quite a number of women, about 70%. And in about 15% of them, it's not adequately diagnosed. I'll show you in the next slide what you need to diagnose it. And then in about 50% of the patient also, they will have diabetes before the age of 40 if they've got PCOS. So it's a metabolic disorder in women of reproductive age, multifaceted presentation, but mostly you have hyperandrogenism, which is a high male hormone. So this we can see from excessive hair that the women will have, and also acne, they'll have severe acne. So it means they have a high male hormone. Then you look on ultrasound for the polycystic ovaries. We actually do count them because to make a diagnosis, you need at least 20 follicles. And you need to have ovulatory dysfunction, either absence of menses, low menses, irregular menses. So you need to ask, we ask for these specific things when we see a patient that we think possibly has PCOS. But we use this Rotterdam criteria to diagnose polycystic ovarian syndrome. So which says you need only 2 of the 3 disorders to actually make a diagnosis of PCOS. And you must have excluded other causes of possibly the high male hormone and so forth. So you must exclude those causes. So you can then have either all 3, which is phenotype A. You can have the hyperandrogenism. You can have the ovulatory dysfunction and the polycystic ovaries. So that's type A when you've got all 3. So type B is when you have a hyperandrogenism and ovulatory disorders. Type C, hyperandrogenism and PCO. And type D is when you have ovulatory dysfunction and PCO. You can ask yourself, why do we want to know which type you are? Because we know that the types that have hyperandrogenism are usually the most severe. The types that don't have hyperandrogenism, like the type D, have minimal symptoms of PCOS. So we also worry about PCOS because it has very long-term effects. So it's not only about what you have now, but we worry that later on in life you might have reproductive problems, and this is infertility. There might be cancers. Because of the high male hormone, testosterone gets converted to estrogen. Estrogen makes the lining of the womb overgrow, endometrial hyperplasia, and this can cause cancer later on in life. And then you can have metabolic issues like obesity, abnormal lipids, impaired glucose tolerance, which can lead to diabetes, a metabolic syndrome, and you can have cardiovascular disease. And later, when they fall pregnant, they can have obstetric problems like early pregnancy loss, diabetes, gestational diabetes, pregnancy-induced hypertension, and all the neonatal complications that go with that. Then, of course, is issues of the poor self-image, reduced quality of life, anxiety, depression, and sleep disorders that are associated. So it's not just about the disorders, we worry also about the long-term effects. So what do we need to do to decrease this risk? The first line is obviously lifestyle modification. Diet, exercise, we say the recommendation is 30 minutes of moderate intensity exercise daily or 150 minutes per week. And weight loss, and we recommend 5 to 10% weight loss. Most patients, they see their menses after that 5 to 10% weight loss. Some of them, if they were infertile, they become fertile. So this is why this is the first line. Before we start intervening, we want to make sure that we can first try and use this lifestyle modification. So smoking cessation, behavioral techniques are also important. All of these have been shown to also reduce those long-term consequences that I spoke about. So then is medical therapy, insulin sensitizers for those that are insulin resistant. Then I said there's abnormal lipid profiles, then you can treat that with cholesterol lowering drugs, manage the blood pressure, and there are other obesity drugs. So in severe cases of severe obesity, then you can consider things like bariatric surgery. So what medication do we use? Again, you find out what is the complaint of the patient. If patient you've diagnosed as PCOS comes to you, you can't now give them medication to make them fall pregnant when that is not what they want. So if the issue is, I've got acne, so then you manage the acne. I have menstrual problems, irregularity, amenorrhea, I'm not menstruating, seeing my menses, then you can give oral contraceptives to make their cycles regular. If there is hirsutism, the hair, the excessive hair, then you can give anti-androgens to treat that. And the anti-diabetic drugs, as I said, if there's insulin resistance, you must treat that. And then if the problem is fertility, you can start giving the clomiphene citrate or the letrozole to help them to ovulate so that they can have a baby. Or if that doesn't succeed, then you can go higher and do IVF or give gonadotropins to assist them. So in conclusion, this is a multifaceted disorder, has long-term implications for the patients. So you have to identify and monitor all the comorbidities like high blood pressure, diabetes, dyslipidemias, and endometrial hyperplasia, and manage, modify the associated long-term health risks with diet, exercise, and induce that cyclical bleeding. And then you treat whatever the patient concern is. If it is hirsutism or excessive hair, infertility, irregular, you address what the complaint is. So, and then this must always be managed in a multidisciplinary manner. And you must consult the dietitian, the physician, the gynecologist, and the fertility specialist. So I hope in a short space of time I've been able to address both issues. So I will give time for questions now.
Yep. Has anybody got any questions for Professor Nene? Don't be shy. Just because she's, you know, our representative for the World Health Organization, there's nothing to be shy about. No questions at all? Oh, Karabo.
Too much information.
Good afternoon, Dr. Nene.
Hello.
I've got a question here from TikTok.
TikTok.
Yes, you are live. And someone is asking, I'm not sure if it's related to the subject you're talking about, but there's a question here that says, how do you treat alphobia? Alphobia.
Alphobia?
Alphobia, yeah.
I'm not sure what alphobia is, sorry.
Okay.
Maybe someone else. Does anyone know what all? So, sometimes, my daughter uses so much of language that I don't know, that I even say, is this in the English dictionary? She says it's urban dictionary. So maybe this is urban dictionary. Maybe ask her to explain and then we can take, yeah, okay.
Any other crisis? Sorry. Any other questions? No? Professor Nene is not doing one-on-one, so if you have got any questions, you need to ask them now.
Another one says, is PCOS same as fibroids?
So PCOS is specifically an endocrinology disorder that is because of the polycystic ovaries. The ovaries have many follicles in them, so it's ovarian disorder. Then it's hyperandrogenism, which is high male hormone, and as I said, menstrual abnormalities. The fibroids are masses that appear in the uterus. They can be in the muscle of the uterus. It's actually a disorder of the smooth muscle of the uterus. So it has a mass there that can either grow outside of the uterus or hangs from outside or become in the muscle of the uterus, or it can hang inside what I call the cavity, the endometrial cavity. So those are well-defined masses that you can see on ultrasound that this is a mass in the uterus, and we can describe that as a fibroid.
Another.
So it doesn't have to be on PCOS or endometriosis. I can also leave my colleagues there. There's Dr. Matlacha that can answer the questions at the chat.
Excellent.
I wanted to ask about endometriosis because you said before we go in for surgery, we must make sure that the doctor is actually, a specialist in that.
Yeah.
I mean, as a patient, I wouldn't know better than when I ask you and you tell me that you are. How can we actually make sure that I'm allowing the right doctor to actually do the process?
Okay.
On me?
So firstly, there must be a gynecologist.
Yes.
Right? And secondly, you are allowed to ask the doctor. You say you are going to take me for surgery. What are we going to do? So the days of going to diagnose at surgery are gone. So when we go for surgery, we must know exactly what we are going to do, which means we must think that either there's an endometrioma, I'm going to open the cyst, I'm going to drain it and take the fluid out, or I'm going to remove the ovary, whatever the case might be. So they must be able to explain to you exactly what it is that you are going to do. So as I said, that if there's kissing ovaries from the endometrioma, we always think that there is possibly the deep infiltrating endometriosis, meaning there's bowel that is stuck there. So the doctor has to know that beforehand, because they must expect it. We don't want surprises when we're operating. We must know that possibly there's going to be bowel there, and this is how I'm going to approach it. So you can ask the doctor. There's nothing wrong with asking. And actually, it is your right to say, doctor, you say I've got endometriosis, and you say I'm going for surgery. So what are we going to do at surgery? And are you appropriately skilled for that surgery? There's nothing wrong, because if they are not appropriately skilled, they must refer to someone who is. So if I say I'm appropriately skilled, but I suspect there's going to be problems here, I mean, I, as a fertility specialist, know this, and everybody else who's an experienced gynecologist, they know this, that you know that here I'm going to have problems. Then they will either call a colleague and say, come with me to theater, the one who's appropriately trained, or refer you to the person that's appropriately trained.
Okay.
Thank you, Professor Nene. We appreciate it. Thank you for your time.
Good.
Okay, everybody, online and here. Yes, give a round of applause. Yes, thank you.